Good afternoon, everyone, and welcome to the Leadership Development Group's webinar entitled The Future of Healthcare After the Midterm Elections, being presented by TLD Group consultant Dr. Kent Bottles. My name is Lisa Clark, and I am the Director of Operations and Coaching at the Leadership Development Group. Just a few quick notes before we get started. Please note that all attendees are automatically on mute for the duration of the webinar. We will be taking questions. Please feel free to submit your queries via the questions box on your GoToWebinar control panel, and they will be presented to Dr. Bottles at the appropriate time. Please note that this webinar is being recorded. We will provide a link to the recording to all attendees. We appreciate your attendance and hope that you find this webinar valuable. I will now turn it over to my colleague, Tracy Duberman, President and CEO of the Leadership Development Group, for a brief introduction. Tracy?
Thank you, Lisa, and welcome everyone. Kent, next slide. I am delighted to welcome you to the fifth webinar in our ACA series, The Future of Healthcare After the Midterm Elections. Once again, this webinar is being presented by our well-versed on quote-unquote all things ACA, TLD Group Advisory Board member and Thomas Jefferson University College of Population Health lecturer, Dr. Kent Bottles. But first, just a bit about the Leadership Development Group. Next slide, Kent. Great. Our singular focus at TLD Group is to develop leaders across the various sectors of the health industry to lead transformative change. We do so through our customized talent development solutions delivered with our faculty of experts, health industry coaches, consultants, and academicians. Next slide. We see great value in the converging of the various sectors within the industry to positively impact population health. And we know that this requires collaboration in bringing together groups that are diverse in mission, vision, values, purpose, perspectives, culture, and expertise. Next slide. Our work and research with leaders from the various sectors of the health industry led to our research, which reveals a set of leadership competencies and mindset for the new health ecosystem leader, capable of building collaborative partnerships to enhance health and well-being. You can learn more about our approach, the Health Ecosystem Leadership Model, in our new book, From Competition to Collaboration, How Leaders Cultivate Cross-Sector Partnerships to Drive Value and Transform Health, which was co-written by my TLD Group Advisory Board Chair, Dr. Bob Sachs. The book has just been published by Health Administration Press. We're very proud, and released a few months ago and can be purchased through our website or, of course, through Amazon. Next slide, please. And now on to our featured speaker, a true health ecosystem leader and expert. Today, it is with great pleasure that I introduce our timely webinar on the future of healthcare after the midterm elections, presented by TLD Group's colleague, Dr. Kent Bottles. Dr. Bottles is a keynote speaker, consultant, and thought leader in healthcare who brings with him over 25 years of physician executive experience. He received his BA in history from the University of California, Berkeley, his MD from Case Western Reserve University School of Medicine, and he is board certified in anatomic pathology and cytopathology. Before I hand the mic over to Dr. Kent Bottles, I'd like to remind you all to type your questions throughout his presentation. Tara Satlow, our VP of Client Solutions, will facilitate the Q&A portion of today's webinar. Without further ado, Kent, take it away.
Thanks so much, Tracy. And I'd like to thank Tracy and Tara and Lisa and everyone else at TLD Group. This is the third time I've been called upon to opine on the results of the midterm elections that occurred just over a month ago. And it seems like every day something new happens that changes my prognosis for what's going to happen with healthcare in the United States. I think it's fair to say that at the federal level, we're going to see gridlock. And that's because the GOP attempts to repeal the ACA are pretty much dead on arrival. You may recall that the House of Representatives over 70 times in the last few years voted to repeal the ACA. But now with the Democrats taking the House, it looks like that's not going to happen anymore. you may recall that the Democrats had to flip 23 seats to assume majority in the House of Representatives, and right at this moment, they've flipped 40 seats. There's one seat in North Carolina that looks like there may be a revote, so they'll either be at 40 or 41 seats that have flipped, and that will really stop any attempts by the government to repeal the ACA. However, that doesn't mean that changes won't occur. The Republicans continue to chip away at the edges of the ACA by using administrative control that they still control HHS. But it looks like the Democrats will clearly respond with House oversight, so Seema Verma and Alex Azar will be brought before the House to answer questions about all of their attempts to chip away at the edges of the ACA. If not much is going to happen at the end of the day at the federal level, there's a lot of stuff going on at the state level. And I think that it would behoove all of us as healthcare leaders to look at each of the states individually. There'll be more transparency. The GOP has already started to approve Medicaid work requirements, which we'll talk about. And that's another thing to think about, is that I think we really got to understand how important Medicaid is becoming, both at the federal and state level. The GOP is also issuing guidance that states can sidestep the health coverage that's mandated by the ACA. And some states are responding by passing individual mandates of their own in each state. Other states are actually looking at legislation for Medicaid buy-in that would allow others to buy into Medicaid. Reinsurance programs to dampen premium increases are being explored in some states. Some states are actually advertising to increase ACA enrollment because the federal government has cut by 90% the money that they've allotted for advertising for enrollment. And it's worth noting that ACA enrollment, I think, ends in about 3 days from now in most states. Now, it's important to know that there are some exceptions to that. California, Colorado, DC, Massachusetts, Minnesota, New York, and Rhode Island all have extended the time that people can sign up for the ACA marketplaces. But in most states, it does conclude on December 15th. And that's one way that the GOP has been chipping away at the ACA, is that a year ago, they cut in half the enrollment time. And then obviously Medicaid expansion, which was affected by the election. I think Paul Keckley is someone that I follow closely on Twitter. Every Monday, he has a blog post that comes out. And a while ago, he talked about U.S. healthcare is in purgatory. Is healthcare a fundamental right or privilege? Why do we spend so much for such poor outcomes? Should healthcare be available anytime, anywhere, any place, and free? Physicians are well paid, trusted, and burnt out. We need more clinicians, but the guilds control access. We don't spend adequately on social determinants of health, some of the subjects I teach at Jefferson's College of Population Health. Politicians certainly don't confront the difficult healthcare issues, and we endorse affordability but shun cost transparency. So that gives us the first polling question. We'll share with you how over 140 people signed up for this webinar. We'll try to get your opinion on the following question.
Okay, the first question is, do you think that health care in the U.S. should be considered a right, a privilege, or it's complicated? We'll give you a few moments to consider that question. Okay, about half of you have voted. All right, I'm going to close the poll now. And it seems that 65% are saying that healthcare in the U.S. should be considered a right, 5% consider it a privilege, and 30% consider it complicated.
Well, that's about what I usually find when I lecture around the United States. Sometimes the people calling it a right are even higher than 65%. But that's one of the problems we have, is I don't think that there's an agreement in the United States that it is a right, at least by the way that we pass laws. This slide shows requirements for markets. I'm sometimes reminded by my friends on the right that we could solve all of our problems with healthcare if we just let the market take care of it and get the federal and state governments out of healthcare. if I look back on my economics training at Berkeley, I don't think healthcare has ever been a market in the United States. And I went back to my old economics textbook and found the requirements for free markets are that consumers and supplier of goods and services have perfect information. We certainly don't have that in healthcare about price. Consumers and producers are rational. Danny Kahneman and Amos Tversky have taught us that with behavioral economics, consumers and producers are not rational. It's easy for producers to enter markets. That's certainly not true in healthcare, where you have to have an MD license to be a provider at that level. In any market, there are large numbers of firms selling a homogeneous product. As Zach Cooper has taught us and others, it looks like consolidation is reducing the number of firms that are selling hospital services, and individual firms cannot affect market prices. So I just want to remind us that we don't have a free market in healthcare. It's also worth noting that there were problems with American healthcare before the ACA was passed. Cost, its contribution to the federal budget deficit. If we spend too much on healthcare, we can't spend money on things we care about, like a wall or more weapons or infrastructure or the environment. Quality rankings, we don't do that well compared to other industrialized countries. Access, before the ACA, about 20 million Americans didn't have insurance. Financial hardships, personal bankruptcies caused by high costs of healthcare. Small variations of cost and quality that the Dartmouth Atlas pioneered. Shortages of primary care physicians and mental health providers. And even before the ACA was passed, if you had to get your health care in the individual market, you didn't get your health care from your employer, it was expensive and uncertain. Now, I think we all know that we spend a lot more money than other industrialized countries. This is 2016 data, which shows the United States spending $10,348 per capita, and the comparable country average down there in the middle in light blue is about $5,169. Now, just last week, we got new data on this, and the trends are about exactly the same. But the 2017 National Health Expenditures Report came out last week, and we now spend $3.492 trillion on healthcare. The per capita cost is up to $10,739 per person. Also, we had a slow annual growth rate of only 3.9% over 2016. That's the slowest annual growth rate since 2013. But a lot of experts think that may be an anomaly and that we really haven't stopped the cost curve problem. I always like this slide, which shows that if consumer prices grew as fast as healthcare since 1945, a dozen eggs would cost $55, a dozen oranges would cost $134, and a gallon of milk would cost $48. I went to Costco in King of Prussia near Philadelphia last week and bought my usual 2 dozen eggs, and they cost $3.48, not a dozen eggs for $55. So at least by this crude measurement, healthcare prices have grown really, really fast. And that's certainly true about hospital price growth. On the left-hand slide of this slide, you can see that the economy-wide inflation has grown about 450% since 1960, but hospital price growth is almost at 1,600% increase. So that really is an explosion in spending. This is an important article by Zach Cooper and his group at Yale called The Price Ain't Right. I just took one of their slides about colonoscopy facility prices. Now, I know nobody on this webinar is old enough to have experienced a colonoscopy, but I've had 3. And I actually live in Philadelphia. So if you look in the middle down there at the bottom, each of those pink bars is a different hospital that provides colonoscopies. And you can see that from on the left, it looks like a colonoscopy at that hospital system would be $800. And on the right, the hospital system is charging up to almost $4,000, which is 5 times different minimum to maximum ratio. That's unsustainable. And it's not just in Philadelphia. If you look above Atlanta, it's even worse at 5.76 minimum to maximum ratio. So prices are all over the place, and that's a real problem. This article, The Price Ain't Right, you can get at healthcarepricingproject.org, and they've really concluded that there's extensive private spending variation within across markets, up to 400% within markets and far higher than Medicare across markets. Price is the primary driver of spending variation for the privately insured. And monopoly hospitals, we're having a lot of consolidation. If you have a monopoly hospital in your area, you have a 15.3 price premium, which is a problem. Let's talk about, make sure we understand how Americans are currently covered. About half of Americans get their health care from where they work. Now, we all know that that's an aberration from price controls in World War II. When GIs were returning from World War, employers couldn't give them a salary increase, so they lured them into employment by offering healthcare insurance. It's worth noting that most other countries don't tie healthcare insurance to employment. Medicaid now covers 20% of Americans, and that's unusual because when Medicaid was introduced in 1965, it was really thought to be an afterthought after Medicare. Medicare now covers about 14% of Americans, and the non-group individual market, where people now buy their insurance on the ACA marketplaces or exchanges, really only covers 7% of Americans. So what does that kind of mean in terms of numbers? Employer-based insurance is about 156 million Americans. Medicaid and CHIP is up to 74 million, which is really a big expansion we need to talk about. Medicare is about 55 million, and this non-group individual market where people buy their insurance on the ACA marketplaces is about 17.5 million Americans. Now, when we hear about that the ACA is in a death spiral, which it is not, when we hear about that premiums are really going high, we're really talking about 6.7 of the 17.5 million. Now, why do I say that? I say that because 10.8 million of the non-group individual market get federal subsidies. As part of the ACA, as you recall, there were federal subsidies so low-income people could buy insurance on the exchanges. And so it's when you hear about terrible people being priced out of being able to buy insurance on the ACA marketplaces, it's 6.7 million people, not a small number, but certainly not a number that compares to the employer-based insurance of 156 million. So most of the people that are affected negatively by the ACA are in that 6.7 million who make a little bit too much money to qualify for low-income subsidies. I think that's an important point to look at. I think it's also important to remind ourselves that Medicaid and CHIP cover 20% Americans, including 3 in 5 nursing home residents, 2 in 5 people with disabilities, 2 in 5 children, and 1 in 2 low-income individuals. So Medicaid has exploded and is really a huge part of coverage in the United States. Now, the Kaiser Family Foundation is a great place to get graphs and charts and information. And this is just in 2018 and August of 2017, the approval and disapproval rate of the ACA. You remember that before, years ago, when the ACA was first brought into play, that it was very unpopular. And it actually contributed, probably was the main contribution to the GOP taking the House and the Senate in the midterm elections during the Obama administration. But what's happened now that 20 or more than 20 million people have obtained insurance on the ACA, what's happened now is that for months, it's been more popular than unpopular. So we see here in August on the right-hand side of this slide, August of 2018, over 50% of Americans approved of the ACA and about 40% disapproved. So polling question number 2, please.
Sure. Do you think that public approval for the ACA will remain above 50% throughout 2019? Yes or no? We'll wait for responses. Okay. All right, I'm closing the poll. And it appears that 79% of people think that the approval will stay above 50% in 2019, with only 21% saying no.
I think that's probably right. And the reason I think it's right is it's really hard to take away something once you've given it to people. The early years when the ACA was so unpopular, people hadn't really gotten their health insurance under the ACA. It took a couple of years for it to get up and running. And I think once you give something like Medicare or Social Security or a benefit to people, boy, taking it away from them, I just think is really difficult to do. And that's, I think, a contributing factor to the Republicans losing control of the House of Representatives in the recent midterm elections. Healthcare became a prominent issue for the Democrats, and they were pretty disciplined about saying, who do you trust to protect your health care? Who do you trust to protect the pre-existing conditions changes? And at least it looks like with the 40 House seats that flipped, the Democrats had a winning issue there. Now, I know most of you have not read the entire 2,700 pages of the Affordable Care Act. I have, which only means that I have no life and I'm a very boring person. So if you come to Philadelphia, you really don't want to take me out for a drink or have dinner with me because I will just talk about policy, which is not very interesting. But my friend David Nash, who's the Dean of the College of Population Health at Jefferson, has popularized that he can summarize the entire 2,700 pages of the ACA in 4 words: no outcome, no income. And basically what they're saying there is, because the federal budget deficit is so high, and because healthcare contributes to the federal budget deficit so much, that finally people are saying, you know, we're going to have to hold hospitals and doctors by name accountable for both cost and quality. And that's where you get into this idea of value. So value equals outcomes over cost. Value is trying to decrease per capita cost and increase measurable quality. Also, if possible, increase the ease with which people get their health care. So basically what's happening is that almost all the experts on the left and the right think that we should convert from fee-for-service, which contributes to overuse, to value-based payment systems. And that's in MACRA and MIPS. That's in payments to hospitals, MACRA and MIPS obviously being payments to physicians. So basically this no outcome, no income is that the federal government, which pays for a lot of healthcare, approaching half of all healthcare expenditures in the United States, wants to get value for its income. Now, as I said, we're in the middle of open enrollment season right now, and you can see here open enrollment from 2014 to 2018 that it's kind of leveled off at about 12 million people. In 2018, people were surprised that 11.7 million people signed up. They were mostly surprised because the Trump administration, which is administering the ACA, really did a number of things to try to curtail enrollment. Remember, we have the odd proposition that we have an administration that really doesn't want the ACA to exist, calling the shots in the rules. For example, they cut the advertising budget from $100 million to $10 million. They cut the budget for navigators who help people sign up for the ACA. They also cut the amount of time for enrollment in half. They also shut down the ACA enrollment website every Sunday for maintenance. So right now, as I said, we're in the middle of ACA signups, which ends for most states on December 15th. And right at the moment, we're about 10% down in terms of ACA enrollment. We don't know. Usually the last couple days are really heavy enrollment, and we really don't know whether the enrollment will continue at whatever level. But I think it's hard to say that the ACA is in a death spiral when 11 to 12 million Americans are getting insurance through this program. A recent article by Reed Abelson and Margot Sanger-Katz, really excellent healthcare reporters from the New York Times, and I recommend almost any article they write. Just from a couple days ago, why is Obamacare enrollment down? Why is it down 10% now? One that we're going to talk about is that the individual mandate, the part of the ACA that said everybody has to have healthcare insurance, was actually removed by the tax cut law. They also administratively through HHS approved new options where people could buy insurance that didn't include all 10 essential health benefits that are required under the ACA. The idea here is that young people would buy less expensive insurance that doesn't cover as much. The problem with that is that may siphon off people from buying insurance on the ACA marketplaces, And the smaller the insurance pool you have, then the higher the premiums tend to be. The expansion of Medicaid may be playing a role in fewer people sign up for the exchanges. More people having jobs, they may get their insurance through their job instead of the ACA insurance period. Some experts think it's because people don't know about the sign-up period because of the curtailment of funds federally to advertise it. And so we don't know what the final number will be, but it looks like right this moment, it's about 10% down from the previous year. So that brings us to polling question number 3. We're anxious to know your opinion about the following question.
Why is ACA enrollment down for 2019? Is it that the individual mandate has been eliminated? Is it that new narrow insurance options that are cheap are available? Is it that more jobs mean less need? Or is it that people don't know that they need to sign up? So we would love to get your opinion on this. Give it a few more seconds. Okay. I'm closing the poll and sharing the results. It seems that we have a tie as far as the fact that the individual mandate has been eliminated, with 29% believe that, and 29% believe that people don't know that they need to sign up. And also 29% believe that more jobs means less need. The least popular option is that new narrow insurance options that are cheap, coming in at 14%.
That's probably about right. It's clear that there's been some efforts by the Republican administration to curtail enrollment in the ACA, but it's not at all clear why that's occurring. I think it's probably true that these new narrow options, these so-called non-ACA compliant insurance plans, probably are not contributing because those are relatively new offerings that are happening. I think it's also interesting that, as we said, in California, the enrollment period is going to last until January 15th. In Colorado, it will last till January 12th. In DC, till January 31st. In Massachusetts, till January 23rd. In Minnesota, till January 13th. In New York, till January 31st. And to Rhode Island, till December 31st. So states that run their own marketplaces are able to extend the sign-up period. And some states have actually allotted money for advertising and for navigators. So it really depends on whether your state legislature is controlled by Democrats or Republicans, and whether your governor is a Democrat or Republican. So it'll be interesting to see what the final numbers are. It'll take a few weeks for us to get that. Actually, probably won't be final until the end of January because of some of those laggard states signing up. But I do think that it's fair to say that most experts on insurance do not believe that the ACA marketplaces are in a death spiral. And that's something we've heard Paul Ryan and other Republican leaders say. That's probably just not true. Now, I've said that we want to concentrate on states because really, state by state, it's going to be quite different and not quite as much uniform across the United States because of this tension between the states that are controlled by Republicans, the states that are controlled by Democrats, and the administration, which is not real supportive of the ACA. Since I live in Pennsylvania, and this is a good time to talk about the Commonwealth Fund and the Kaiser Family Foundation. If you're looking for information like this, those are two great places to find it. This is relatively recent data for Pennsylvania, where I live, so that following the passage of the ACA in 2010, at that time, 21% of Americans were uninsured and 14% of Pennsylvanians were uninsured. In 2017, it went down to 7% of Pennsylvanians being uninsured. Adults who went without care because of cost, in 2011, it was 15% of Pennsylvanians. Now it's 12%. And you can see the difference there between Pennsylvania and the US average, which is the line on the top there. This is interesting, I think. More federal dollars for health insurance coverage in Pennsylvania. In 2013, Medicaid only got $11.9 billion from the federal government. And in 2018, with the marketplace premiums for low-income people and the Medicaid funding of the expansion, which Pennsylvania passed when they got a Democratic governor and Governor Wolf, it went from $11.9 billion to $20.1 billion. So that's a 69% increase in federal support for health coverage in Pennsylvania. Now, that increase won't be seen, as we'll see, in states that did not expand Medicaid. You may remember that part of the ACA originally was that all states had to expand Medicaid. But then there was a Supreme Court ruling where Justice Roberts said, that's a little bit too much, that states should be able to opt out of the expansion of Medicaid. And so most states that were covered, had elected Republicans to be governor and state legislatures, many of them did not expand Medicaid. When we look at the results of the recent midterm elections, we'll see that that's changing, that slowly some of the states that were red are now voting a referendum and also choosing to expand Medicaid. So again, to look at whether your state is getting more or less federal dollars, you really have to look state by state to see how the ACA is affecting people in your state. And I just wanted to share these numbers because I think it's important to recognize how important Medicaid is and how central to healthcare delivery in the United States Medicaid has become. I think most people still tend to think of Medicaid as an afterthought to Medicare, but it's certainly not true. Here, the ACA marketplace and Medicaid enrollment numbers, about 389,000 people in Pennsylvania have coverage under a marketplace plan. So those are those individuals that don't get their health care insurance from their employer or from Medicare. Those are folks that signed up for one of those ACA compliant plans on the marketplace, on the exchange in Pennsylvania. 85% of those Pennsylvanians who signed up, 85% of the 389,000 received financial assistance. It's called a premium tax credit to help purchase coverage. So they're subsidized. They're low-income people, they're subsidized. If you make a little bit too much money to get this subsidy, so the 15% of people on the Pennsylvania exchange who didn't get a subsidy, they often saw premiums that were higher. But look at the bottom number. This is the one that I think is most remarkable. Almost 3 million Pennsylvanians are covered by Medicaid and CHIP. And CHIP obviously is the Children's Health Insurance Program that's kind of part of Medicaid. But look at those numbers. 3 million people in Pennsylvania get their health care through Medicaid. Only 389,000 get their Medicare, that get their insurance coverage through the ACA exchanges. I just think it's important to recognize that most people still get their insurance through their employment place. That's about 50%. About 20% get their insurance through Medicare, and more than 20% get it through Medicaid, and only about 7% are in the individual market. I think sometimes we overestimate how many people are in the individual market and are affected by the ACA guidelines. This is from Charles GABA, who is someone I follow on Twitter and is someone who's quite good at explaining the ACA. And, you know, I'm asked a lot, how do you keep track of all this stuff in healthcare? And, well, one way, if you want to keep track of it, would really be just to follow me on Twitter. That's at Kent Bottles. Because every day I'm tweeting out links to white papers like the Zach Cooper white paper about The Price Ain't Right, or to slides like this from Charles GABA. But the people I follow, and I follow about 1,000 people on Twitter and about 12,000 people follow me, the people that I find most useful on Twitter are Eric Topol, Andy Slavic, who ran CMS under Obama, and Atal Gawande. These are real experts that you can follow on Twitter. If you're conservative, there are some conservative healthcare experts that are quite bright. Doug Holtz-Akins, who ran the healthcare policy shop for McCain when he ran for president. Avac Roy is one of my favorite conservative experts. And then Michael Cannon of the Cato Institute are really outspoken sort of people that don't really support the ACA. So I think those are interesting people you can follow on Twitter. One way to do it is just follow me, because you'll get all of their links as you follow me on Twitter at Kent Bottles. But Charles GABA is someone who I follow, who's done a nice job of explaining the ACA as a three-legged stool. So what his concept is that the blue leg is stuff that insurance companies have to do differently because of the Affordable Care Act. The red leg is stuff that people have to do, citizens have to do to sign up. And the green leg are things that the federal government has to do to make the ACA work. It's a very complicated law. As we said, it's over 2,700 pages. That's generated tens of thousands of pages of rulemaking, and it's complicated. It's complicated because that's how legislation in the United States occurs. And what he says here is that this three-legged stool works pretty well unless you shorten any part and the stool will wobble. If you remove any of the legs of the stool, it collapses. The reason I bring this up is that the Trump administration has been messing with different parts of this three-legged stool. So the guaranteed issue and community rating on the blue leg of the stool is that part which says that healthcare insurance companies have to sell insurance to everybody, and they can't use pre-existing conditions as a reason to not sell insurance. The essential health benefits on the blue leg is those that the healthcare insurance sold under the ACAs has to cover 10 different conditions, 10 different things. And the minimum AV levels is that you can buy insurance with different levels of coverage, and so different levels of price. Before we go on to the red leg of the stool and the green leg of the stool, I think it's important to recognize that these 10 essential health benefits mean that the healthcare insurance that you buy on the marketplaces will cover things like mental health, will cover things like ER visits, will cover things like maternal child care, will cover things like hospitalizations. Now, the red leg of the stool is the open enrollment period. And we said that the Trump administration has already changed that by cutting it in half. The shared responsibility or individual mandate penalty, which is shown there as part of the red leg of the stool, is that provision of the ACA which said that everybody has to have health care insurance or they will pay a penalty on their taxes when they file their taxes, their income taxes, with the IRS. Now, this was upheld by the Supreme Court as constitutional, but the penalty that was proposed was really quite low and didn't do much to keep people buying insurance. But this individual mandate's been eliminated. It's gone, and it was gone because it was eliminated as part of the Republican tax cut that the Trump administration passed just recently. So that part of the stool is gone. The green part of the legs of the stool are the advanced premium tax credits, which we said are those subsidies that 85% of Pennsylvanians got because they were low income to help them buy insurance on the ACA marketplaces. The cost sharing reductions were a separate subsidy that went from the federal government to insurance companies to offset some of the out-of-pocket expenses for low-income people. Now, the cost-sharing reductions were, Trump stopped paying those in October of last year. So that part of the stool has kind of been taken out. So Charles GABA has now said that his stool kind of looks like this. If you take out the individual mandate on the red leg of the stool, which is part of the enrollee responsibility, and the cost savings have now been taken out of the green leg of the stool. And actually, you could actually say in a way, essential health benefits have been taken out of the blue leg of the stool because of these narrow non-ACA compliant insurance plans that are now being offered by some insurance companies in some states. And we'll get to those in a second. So this is what I referred to as the GOP chipping around the edges of the ACA to weaken it, even though they don't have the votes in Congress to repeal and perhaps replace it. So this, I think, is one way to think about that it will not work as well if you take out some of the requirements. Now, I just wanted to point out that the 10 essential health benefits, so every insurance plan that is purchased on an ACA marketplace has to cover these 10 things: ambulatory patient services, emergency services, hospitalization, maternity and newborn care, lab services. And as a former pathologist, that's very important that you subsidize the path lab. Rehab services, prescription drugs, mental health, and substance abuse care, prevention and wellness, and pediatric services. This is important. If you go back to that mental health and substance abuse care, if you curtail the ACA enrollment in plans that cover substance abuse care, if you cut the benefits for Medicaid patients, you exacerbate the opioid crisis. The opioid crisis in the United States is so bad that for the last couple of years, life expectancy in the United States has gone down, and that hardly ever happens in an industrialized country. And most folks think it's going down because of the diseases of despair, people that are unable to get work, and people that then turn to opioids. It's a complicated problem. I'm just saying, though, that if you sell insurance that doesn't cover substance abuse care, you're not really helping combat the opioid epidemic that we're facing. So now we get to Trump. And again, Commonwealth Fund, Kaiser Family Foundation, this comes from the Commonwealth Fund. So things that, Trump does not like the ACA. On day one of his presidency, he signed an executive order to slow down implementation. He stated publicly several times that the ACA is dead, crippled, or failing, that no one's signing up for it. That's not true. He has scaled back the outreach and education programs. As we said, the advertising budget's been cut from $100 million to $10 million to get people to sign up for the ACA, and navigator programs have been cut. He's terminated reimbursement of insurers for decreasing the cost sharing for low-income enrollees. That's those CSR payments, cost sharing reduction payments that we talked about in the three-legged stool, that he stopped paying the insurance companies. Even though it's stipulated under the law, he should be paying them. He ended the individual mandate, which says that everybody has to have insurance, to create a large insurance pool to decrease premiums with the tax cut bill. And he's talking about approving waivers for Medicaid work requirements and other requirements that we'll get into. The other thing is that we've referred to is these alternative individual health coverage independent of the ACA essential health benefits. So saying that insurance companies can offer narrow insurance plans that are cheap, but they don't cover much. So this short-term insurance is now being offered by some insurance companies. It's being offered for 30 days to 12-month terms. They're not required to cover those 10 essential health benefits. They may not be renewable. And what people sometimes don't realize is that many of these plans don't cover prevention, don't cover pre-existing condition exclusions, don't cover pregnancy, don't cover mental health, don't cover prescription drugs. So what people who study this worry about is that this may increase premiums eventually for people on the ACA exchange plans. Why? Because if healthy people choose these cheaper alternatives, then people will leave the ACA plans, and only ill people will remain in the ACA, and insurance companies will raise the premium rates to cover that. The way that healthcare insurance works, as most of us realize, is the larger the premium pool you have, the more people that you're covering, the lower the premiums, because you can dilute out, not everybody gets sick, and those people that don't get sick subsidize those people that do get sick. The problem is it's hard to predict who's going to need insurance, who's going to have an auto accident, who's going to get a disease. It's hard to predict who's going to need the insurance and who isn't. Trump has also signed executive orders proposing that we expand the use of association health plans. Now, as this article from Robert Pear, who's another great New York Times person, and I think every day it's important for you to read the New York Times and at least the Wall Street Journal, because in my experience, you kind of get a different slant on the same story. The New York Times tends to be more liberal, more supportive of the ACA. The Wall Street Journal tends to be less supportive of the ACA and take a more conservative bent. So I think it's important, at least I try every day, to read both the New York Times and the Wall Street Journal to try to get both sides of the story. But as Robert Pear in this New York Times article talked about, we have some experience with association health plans, and it's not all good. So these are plans where groups of churches or groups of auto dealers or small association groups will try to become healthcare insurers. There's dozens of court cases and enforcement actions where the Labor Department has said that unscrupulous promoters sell the promise of inexpensive health benefit insurance, but then default on their obligations. For example, in Washington State, an association health plan for 300 small employers charged $3 million in excessive fees. There was a Florida case where there was 3.6 million in unpaid claims. What happens is it's relatively easy to get people to buy the insurance, but then if some people get sick, there may not be enough money to cover the hospitalizations. There was a New Jersey plan that aggressively marketed but inadequately funded that left $7 million in unpaid claims for members who bought insurance through this association plan. There was a Florida man who was sentenced to 57 months in prison for embezzling $700,000 from a church association plan. And my favorite one was from Louisiana, where two pled guilty to conspiracy by using money from the trade association plan to pay for spa treatments, diamond cufflinks, evening gowns, and foreign travel. Now, I think it's worth talking about just for a second what Margot Sanger-Katz in the New York Times called a requiem for the individual mandate. So this was part of the ACA that was intended to create a large insurance pool so premiums could be held down. And it actually turns out that it's a Republican idea. It comes from the Heritage Foundation, which is a conservative think tank from the late 1980s. And it was thought that if you made everybody have health insurance, it would encourage individual responsibilities. The Republicans came up with this plan that was in contrast to President Clinton and Hillary Clinton's proposal when President Bill Clinton was president, if you recall. And when Governor Mitt Romney, a Republican, included it in the Massachusetts health care plan in 2006, there was an individual mandate. Hillary Clinton obviously supported it in the 2008 primaries, but Barack Obama was against it during the primaries. But to make the numbers work out, he included it in the ACA. Now, the Congressional Budget Office, which is supposed to be nonpartisan, has estimated that 13 million could lose their coverage with repeal of the individual mandate. And they also estimated that premiums would go up 10%. Now, the way that enrollment worked last year, it looks like the CBO may have gotten that wrong, that almost as many people signed up for the marketplaces without the individual mandate as when it was in operation. Now, it may be that people didn't realize it was no longer in operation. It's also true that the individual mandate penalty in the ACA was so low that it didn't seem to make people buy healthcare insurance. But I think it's worth noting that sometimes healthcare insurance gets so partisan that this individual mandate was originally an idea floated and supported by conservative think tanks, and only later became controversial when it was part of Obama's Affordable Care Act. So we've said that the Trump administration under the HHS is trying to chip away at the edges of this law that they don't really approve of. And that comes down to Section 1332 ACA waivers. Now, I know most of you don't know about Section 1332 because you haven't read the ACA, but I have read it, and I can tell you that this was put into the ACA so that states could experiment, so that states could try to create programs that work for them locally. The states could apply for waivers from all of the requirements of the ACA for provisions governing health plans on the exchanges, for cost-sharing reductions, which Trump eliminated, for premium tax credits, those subsidies for low-income people, for even the individual employer responsibilities. Under the Obama administration, there were several 1332 grants, about 10, approved for reinsurance programs. The idea that you could make the ACA premiums lower by having a reinsurance program for people that got really sick and had high hospital bills. But Trump is using the 1332 ACA waivers to approve association health plans, which we talked about, short-term limited duration plans that don't have to cover the 10 essential health benefits, and maybe most importantly, changes to Medicaid, especially work requirements. So just last month, there were new insurance guidelines proposed by Seema Verma, who runs the CMS and HHS. And these erode the ACA nationwide standards for healthcare insurance coverage. And Seema Verma makes no bones about the fact she's not supportive of the ACA. She was quoted as saying it was a mistake to federalize so much of healthcare in the ACA. So what they're saying is that they're going to look favorably upon allowing the use of federal subsidies to non-ACA compliant health plans. So those subsidies for low-income people that were thought to be only for buying insurance on the ACA marketplaces now could perhaps be used to buy non-compliant plans, and actually allow accounts to mingle federal subsidies with healthcare funds from jobs, providing employer-based insurance. So changing a lot of the wiggle room around the requirements of the ACA. Now, Timothy Joyce is a retired law professor who I just think is probably the best person to read about the real intricate things about the law. He writes a lot for Health Affairs. He also writes for the Commonwealth Fund. And recently he talked about these new guidelines from Seema Verma and CMS. They're actually called State Empowerment and Relief Waivers. And again, he sort of summarizes this in a nice article in Commonwealth Fund from December 4th, 2018, that this directs subsidies to defined contribution individual accounts that can be used to pay for health insurance premiums and other expenses. That's an expansion of the subsidies. Directing subsidies to a wider range of individuals than qualify for premium tax credits or cost sharing reductions under the ACA. Providing subsidies for forms of coverage that could not be subsidized under the ACA, those non-compliant ACA plans, and funding reinsurance programs or state high-risk pools for people with pre-existing conditions. Now, he also points out that this is going to be controversial, that these new guidance from Seema Verma and the CMS may not comply with the guardrails that were contained in the ACA language, so there may well be lawsuits. He also believes that they may be illegal because they didn't go through the notice and comment rulemaking as required by the Federal Administration Procedure Act. Most of the rulemaking for the ACA has gone through a 60-day comment period. Then they get comments from lots of people, and then they usually change their rulemaking to try to take into account some of the problems that have been come up by the comment period. In this case, they didn't go through that. And that he also pointed out that most of the guidance that Seema Verma is providing is derived from the failed GOP bills to repeal and replace the ACA. So again, that's evidence that the Trump administration is trying to chip around the edges of the Affordable Care Act. Now, as I said in the beginning, it's really up to the states. So the individual mandate, which said that everybody has to buy health care insurance to increase the premium pool. In DC and Massachusetts and New Jersey and Vermont, the states have already passed state laws saying everybody in those states must have health care insurance or face a penalty. States that are considering an individual mandate are Washington, California, Minnesota, Connecticut, Rhode Island, Hawaii, and Maryland. You'll note that I think all of these states are considered blue states. Most of them have Democratic governors and at least some Democratic control in their state legislatures. So again, the fact that the federal government has said the individual mandate is no longer operative doesn't mean that states can't say, oh, but in this state you have to have health care insurance because we want to try to decrease premiums. Now, if that's not confusing enough, there's another set of waivers, not under the ACA, but under the Social Security Act. They're called 1115 waivers. And the Secretary of Health and Human Services can waive provisions of Medicaid law to allow states to use federal funds in ways not otherwise allowed under the law. So in this case, states that are mostly red states or considered red states, Arizona, Montana, Iowa, Arkansas, Indiana, Kentucky, Michigan, and New Hampshire have all expanded Medicaid using these 1115 waivers. In Kentucky and New Hampshire and Maine and North Carolina, Alabama, Mississippi, Arkansas, South Dakota, Utah, Arizona, and Kansas and Michigan have all submitted waivers under this program to require work requirements to enroll in Medicaid. So this turns out to be controversial. The 14 states that are applying to require work to enroll in Medicaid, let's remember that Medicaid is a joint project between the federal government, which provides Medicaid funds, and the state government. Each Medicaid program in each state is quite different. In Arizona, it doesn't cover very much. In Minnesota, it has really rich, quite generous benefits under Medicaid. So the state governments view Medicaid as a problem because the state budgets require a matching with the federal budget, and the states have trouble sometimes not having enough money, so that they often worry that money going to Medicaid is money they can't spend on police or on education or on roads or on other things. So Kentucky, under this waiver system, applied for saying that we're going to change our Medicaid expansion so that you have to be working, if you're able, to get Medicaid. Well, a federal district court judge had to rule on it because the National Health Law Program, the legal aid of Arkansas and the Southern Poverty Law Center, filed a lawsuit against this Medicaid work requirement. And the federal judge said, I don't think this is kosher because I think that the law is supposed to try to get people to have more coverage under Medicaid, and this would be a problem. And they received 11,000 comments about problems with this program. And so that's still, I think, going to be appealed. That's still, it's right now, I think, overturned, but there's definitely going to be some lawsuits about whether or not this Medicaid work requirement can go into function. So I think it's worth noting that several other states have been trying to do this. And one of the reasons is that they're worried about their state budgets. They don't know if they have enough money to support Medicaid. I think it's worth looking at Healthy Indiana Plan 2.0. Why? Because this was a plan to expand Medicaid, but was designed by Seema Verma before she became head of CMS. She was a private contractor who helped Mike Pence, who you may remember, was governor of Indiana, and she did this unusual waiver where she required contributions to a health savings account from the low-income people signing up for Medicaid. And if you missed payments, even though they were small payments, to your HSA, you would get reduced benefits and eventually lose your benefits. And you know, some people said, oh, this is going to be terrible. Some people said this is going to be great. When you actually look at the coverage for expansion states, Indiana was right in the middle, 13 people, ranked 13 out of 27 in terms of how many people they were covering. Indiana now has said that they want to have a work requirement as well, like Kentucky. So it's worth looking at the Seema Verma designed Indiana Plan 2.0. It has worked better than some liberals thought it would work. It has not worked as well as some conservatives thought it would work. So as we said, there was a lawsuit, and the district court overturned the approval of the work requirement. And he said work requirements are not unlawful per se, but you've got to assess the impact on people's health coverage. And he felt that expansion beneficiaries had to be treated equally with people that were traditionally on Medicaid. And he wanted high quality evidence as the heart of lawful administrative decision making. So this is a slide from Commonwealth Fund, which talks about why this is such a big deal. Now, the SNAP requirements is a nutritional assistance program, and it has a work requirement. But if you look at the pie chart down there on the left, that the target of the SNAP work requirements was about 240,000 people in Arkansas, Indiana, Kentucky, and New Hampshire, all of whom have applied for a work requirement for Medicaid expansion. If you look here, the target for Medicaid expansions is 1.5 million. So the point here is that they're really trying to target a larger part of the population. Now we have a little bit of experience because Arkansas, as we said, has already done a work-wide expansion for Medicaid, and we now know the results of that. And about 12,000 people were purged from the Medicaid rolls since September. So 12,000 people were on the Medicaid rolls. They were kicked off because they couldn't meet the work requirements. And some people say that work requirements can work if you have an education program to help people get jobs, if you have some support for folks, but that the way that this law was fashioned in Arkansas made it very difficult to comply with the law. You had to work 80 hours a month to qualify, and you have to report every month on your work status. Now, some folks that are working work for McDonald's or other fast food stores and don't always know how many hours of work they're going to get. Also, the problem was you couldn't report directly over the phone or in person or by mail. You had to report monthly by computer. It's been shown that many of the people in Arkansas who are on this program don't have access to computers. Also, the website is shut down every night between 9 p.m. and 7 a.m. for scheduled maintenance. And some health IT experts say that's really not necessary to do scheduled maintenance. So if you're a liberal, you sometimes are against these work requirements, saying they're just putting bureaucratic obstacles in the way of poor people who need to get health care insurance. And if you're someone who supports these work requirements, you're saying, look, work is a good thing. And if people work, they feel better about themselves and have more self-esteem. And there shouldn't be a problem about requiring work requirements for people on Medicaid. That brings us to the polling question number 4. What do you think is the real reason why some states are asking for a waiver so that they can require work requirements for people on Medicaid?
Yes, thank you, Kent. Do you think work requirements for Medicaid are basically about getting people jobs to increase self-esteem, or cutting state budgets by getting people off of Medicaid? Give a couple of more seconds. Okay. All right. It appears overwhelmingly that people believe that, by 88%, people believe that it's about cutting state budgets by getting people off of Medicaid. Only 12% believe that it's about getting people jobs to increase self-esteem.
Okay, let's talk just a second about state reinsurance programs, which is another way that these waivers are being used. They were used this way under the Obama administration. They've been adopted by Arkansas, Maine, Maryland, Minnesota, New Jersey, Oregon, and Wisconsin. These are reinsurance programs, as I mentioned, to cover high expense patients. And in Maryland, their premiums dropped after they did this program. Now, another thing that's happening state by state that hasn't gotten much press is state Medicaid buy-in tracker. So basically, what this slide shows is that some states are now saying, hey, let's have a way that people that don't want to get health care insurance from their employer or can't get it, they can buy into Medicaid. Nevada, New Mexico, and Delaware are far along on proposing proposals like this. Maryland and Colorado are looking at it. Oregon and California are looking at it as well. And there's bills introduced in Massachusetts, Minnesota, Connecticut, Iowa, Washington, Wisconsin, and Wyoming. So let's get to the election. I said before that the election was a healthcare election. And I think if you look at this Kaiser Family Foundation graph, that is true. On the left-hand side, the percent who say each of the following issues is very important in making their decision about who to vote for Congress, healthcare came in first at 71%, over the economy and jobs at 64%. And that's unusual. Usually the economy is the number one issue. On the right, it says when asked to choose one, the percent who say that each of the following is the most important issue. So the most important issue in making decisions about who to vote for Congress, 30% said healthcare, 21% said economy and jobs. Majorities say it's very important that protections for pre-existing conditions remain the law. On the left-hand side, prohibits health insurance companies from denying coverage because of a medical history. 75% said that's important. Prohibits insurance companies from charging sick people more. 72% thought that was more important. Now, this is important because some of those healthcare insurance plans that are now being offered in some states that don't cover the 10 essential health benefits actually would allow healthcare insurance companies to discriminate against people with pre-existing conditions. With healthcare issues mattered the most to some voters. This is exit poll votings, and the top was prescription prices, single-payer coverage, Medicare funding, Medicaid funding, the opioid crisis, abortion, malpractice reform, and information security. So these midterm election exit polls, 41% identified healthcare as their top issue. 58% favored Democrats versus 34% favoring the GOP for who would best address concerns about the pre-existing condition issue. The Commonwealth Fund found more than 70% that the healthcare system needs major changes, and Nancy Pelosi, who's likely to be the next Speaker of the House, said healthcare was on the ballot and healthcare won. Now, there were some, as we said, we got to look state by state. So there were ballot initiatives to expand Medicaid in red states that had been reluctant to do so in the past. So Nebraska, Idaho, and Utah all had governors and legislatures that didn't really want to expand Medicaid. They had ballot initiatives because the voters could put a ballot initiative on, and all three of those ballot initiatives passed. Now, also in Maine, Maine's a little bit different. Maine had already passed an initiative to make Medicaid expansion occur. Governor LePage, who was a conservative governor, refused to implement it, even though several court rulings said he had to. Well, Maine elected a governor who says that she will implement Medicaid expansion. Governor LePage will no longer be governor of Maine. Kansas and Wisconsin, which have not expanded the Medicaid expansion, also elected governors who support expansion. So here's a chart here showing the results. Montana is one that is a little bit not in the trend. Montana had an initiative that would extend the Medicaid expansion funding, and it did not win. So that was kind of a anti, if you will, Medicaid expansion vote. But Idaho, Utah, and Nebraska all passed initiatives. Maine, as we mentioned, now has a governor who wants to be supportive. And Wisconsin and Kansas now have governors who support Medicaid expansion. Why is this important? Here's a Vox chart. And Vox is another good place to get healthcare information. You have to remember, though, this has more of a liberal leaning to the Vox information as opposed to some of the other sources that are more nonpartisan. But this chart says that if you look at the green states, those are states that have already expanded Medicaid. Okay, so those are mostly blue states in a way. If you look at the fuchsia or red states, those are states that have not expanded Medicaid. Those are mostly states that have been controlled by Republicans. And what they're saying here is that almost 500,000 Americans could gain coverage as a result of these recent midterm elections. They're saying that there's about 90,000 potential in Idaho, about 130,000 in Utah, about 100,000 in Nebraska. They also talk about Kansas and Maine. For some reason, they didn't include Wisconsin, which also elected a governor who is supportive of Medicaid expansion. Now, we've said that the Democrats control the House, but the Republicans will continue to control the Senate and the White House. What are the Democrats' top healthcare priorities? Let's talk about them, but let's realize that they really haven't got much chance of getting these passed. Stabilizing the ACA marketplace premium costs, controlling prescription drug prices, investigating the Trump administration actions that have undermined the ACA. So you're going to see House committees calling various Trump administration officials to testify. And the House could also intervene in this lawsuit, which 20 states and the Trump administration are challenging the ACA because of the tax cut bill. In district court in Texas, and a very conservative judge, when the tax cut got rid of the individual mandate, some of the state's attorney generals in red states said, aha, that should eliminate the entire ACA. Now, the district court judge he can issue this ruling anytime. It obviously will be appealed if he rules that the entire ACA is null and void. But it's hard to see how the industry would respond to suddenly in the middle of all this, someone saying, now the ACA is illegal. So stay tuned. That district court ruling will come out, but the House could now put a friend of the court brief saying all the problems that this would cause. Stabilizing the ACA markets, they could try to get the CSR payments to insurers reinstated. They could provide money to provide states to pay largest medical claims via reinsurance. That's a waiver we've talked about. They could restore the cuts for marketing ACA enrollments, but that won't pass the Senate. They could have a bill to protect consumers from balanced billing by out-of-network providers. Reining in drug prices is one area where they might be able to have a bipartisan solution. Trump has actually said now that he would like to negotiate for Part B Medicare drugs. Now, Part B Medicare drugs are very high, expensive drugs that are given to patients in a doctor's office. They're drugs that are used with infusion pumps or nebulizers, injectable osteoporosis drugs, erythropoiesis stimulating agents, blood clotting factors, oral end-stage renal disease drugs. The Part D spending's gone up from 2011 to 2016 from 17.6 billion to 28 billion, so they've really been skyrocketing. This program that Trump is proposing that some liberals are in favor of would save taxpayers about $17 billion by having Medicare get the price that's a benchmark of what European countries pay for these drugs. So this would utilize a provision in the ACA Center for Innovation for Experiments. So it's interesting that Trump, who doesn't like the ACA, would use a provision of the ACA to allow Medicare to negotiate for drug prices for Part B drugs. Obviously, the pharma companies are not in favor of this, but this is something that might be a bipartisan partial solution. Certainly, I think you're going to see the House of Representatives have hearings about work requirements, about association plans, and those 1332 guidances. Seema Verma will still be administrator of Medicare, and she will have some uncomfortable hearings before Congress. It's important that they've now appointed Mary May, who ran the Medicaid in Maine, who didn't like Maine expansion. She now serves as a commissioner for health. She's now going to be working for HHS. Medicare for all. I think Democrats would like to pass this. It's not going to pass in this Congress at all. And it actually includes a whole bunch of different proposals that are quite different. One Medicare for all could phase out all private insurance. Another Medicare or Medicaid available to all would allow people to buy into insurance while maintaining private insurance plans. Paul Starr, the famous Princeton sociologist, has talked about midlife Medicare, which would expand programs to uninsured people over 50. And the Center for American Progress, Medicare Extra for All, would be free to those who make below the poverty line. So none of this is going to pass because of the Senate and the White House. Medicare for All is getting more and more favorable. About 70% of Americans say they're in favor of it. However, it could be quite expensive. And one study from a conservative group studied that it would cost about $32 trillion over a 10-year period. Which is obviously unaffordable. That's an estimate that some people contend is not really right. So what do progressives want? What do conservatives want? Progressives really want to protect the Affordable Care Act, but some progressives want to go far beyond the Affordable Care Act. It was interesting when the Affordable Care Act was passed, many of my most liberal friends were against the Affordable Care Act because it didn't go far enough. It wasn't Medicare or Medicaid for all. We talked about midlife Medicare open to ages 50 to 64. There's certainly on the progressive side the cautionary tale of Vermont's failed Green Mountain Care. When Democrats controlled everything in Vermont, they tried to pass just for Vermont a Medicare for all and couldn't do it because it cost so much. What do conservatives want? Some just want to oppose the ACA. Obviously, if you're a Burkean conservative, you want to limit the role of government in healthcare. Michael Cannon, who's a smart conservative healthcare expert, would like to repeal the ACA. Avik Roy, who I've mentioned is one of my favorite conservative healthcare experts, would like a Swiss system with universal coverage, but private insurance and no mandate. Doug Holtz-Eakin, who ran the McCain healthcare shop, wants to change the delivery system. And Senator Ted Cruz is the big proponent of these non-compliant ACA plans. I think this quote by John Podhoretz, who's a well-known conservative intellectual in New York City, is important. If Republicans cannot defend the idea that what's important is the freedom of the individual to make choices about how to live his life, as opposed to the notion that we're all in this together and must participate in healthcare to ballast each other's healthcare outcomes, then we've accepted an essential social democratic principle, and that's a huge concession. What he's saying is that he doesn't like the way that healthcare insurance works, that freedom for each of us to choose what we want, to not have an individual mandate, is more important than having a workable insurance plan that provides a safety net for all. I think the problem with this is that that's a fine intellectual approach to take. It's defensible. However, it looks like because of the ACA getting insurance for about 20 million Americans who didn't have it before, it's really hard to take away something once you give it to people. And I think the American people, in that poll, it said 70% now approve of Medicare for all. Now, they don't really understand what they're saying they approve. I get it. But I think that this ship has sailed, that I think it's going to be harder and harder for Paul Ryan and others to say that freedom is more important than the safety net. We'll see. We'll wrap up now and don't have time for questions. Just to know that ACA premiums for 2019, Alex Azar, the HHS secretary, predicts that silver plans will have a 2% decrease in premiums for the states that use healthcare.gov. Azar credits Trump for this. Experts disagree. An AP analysis says the average premiums across all plans will rise 3%, with 12 states showing premium declines. This from Kaiser Family Foundation says that premiums would have been even lower if the GOP had not been chipping around the edges. That of the 495 silver premiums for someone, $68 of that is added on, so that individual mandate penalty repeal, the loss of cost sharing reduction payments, and the expansion of these loosely regulated plans we talked about. So what they're saying is that if Trump hadn't done some of the things he did, insurance premiums would be even lower. Now, it's important to realize that insurance companies are smart. They are no longer losing money on the ACA. And that was one of the arguments was, well, the ACA is in a death spiral, and so insurance companies will no longer be involved and won't offer ACA marketplace plans. This is from Kaiser Family Foundation showing from 2011 to 2018, the average second quarter individual market gross margins per member per month. It's skyrocketed from $41 to $155. Insurance companies have figured out how to make money on the Affordable Care Act insurance exchanges. And so you can see that they're offering plans. One of the problems a few years ago was that insurance companies might not offer any plans at all. Well, look at this. Here's the change in lowest cost plans. You can see that for a silver plan, and it's difficult because there's different levels of plans, but let's look at this. This is insurance participation on the ACA marketplaces. The blue is that there's 3 or more insurers in each county. The light blue is 2 or more, and the yellow or orange is only 1 insurer plan. You can see that there are no counties that I can find that don't have insurance plans offered on the ACA marketplace for 2019. And recognize we're in the middle of signups for 2019, so we'll see how this goes. But what this shows is the healthcare insurance under the ACA is not in a death spiral. If it was in a death spiral, you'd have lots of counties in the United States where no insurance companies were offering plans because they didn't think they could make money on them. They're smart enough to figure out that they can now make money on ACA compliant plans. So you can see here that on the top, from 2018 to 2019, that it's gone 3 or more insurers in the marketplaces has gone from 48% to 58% of people. So with that, I think that we've had a mad dash through lots of things. Basically, the take-home message is don't think so much federally. Not much is going to happen federally because there's going to be a gridlock. The House will be controlled by Democrats. Nancy Pelosi will be the Speaker. The Senate will be controlled by Republicans. Mitch McConnell will be in charge. And Donald Trump will continue to be president of the United States. I must say, though, also that it sure looks like that there may well be a lot of House hearings on the Russia investigation and other things about elections, which will take the air out of the balloon of trying to do anything for healthcare. So look to individual states if you really want to know what's going on. you have to look at your own state, because it's quite different if you have a Republican governor or a Democratic governor, or a Republican legislature or a Democratic legislature. And just to note that the Democrats did pick up a few governorships, and so that changes the thing, like in Michigan and in Wisconsin, where previously there was a Republican governor, now there's a Democratic governor, and you may see more action on the healthcare reform front. With that, I would love to entertain any questions. We have about 10 minutes for questions, and I'll give it my best. I must say that this is a rapidly evolving and changing landscape, and so what's true today may not be true tomorrow.
Great. Well, thank you, Kent. That was amazing. So much ground covered, lots of it quite complicated, and we got a lot of questions. So what I'm going to propose is I am going to start on the questions. We can even do it kind of a rapid speed round, and whatever questions we're not able to get to, we'll have you send follow-up responses. We'll send to the participants. Sound good?
You're giving me job requirements. I have job security for the next few weeks. Good.
Excellent. Okay, here we go. The request is that comment on two issues. Number one, can you comment on federal and state issues with out-of-network providers? New Jersey just passed a bill which limited payments.
Yes. Quickly, there's been a lot of problems with people going to the emergency room or going to the hospital, having good insurance, and suddenly there's an out-of-network provider that gives you a big bill. Sarah Clift at Vox has done a bunch of work on this for ER bills that you can go to Vox and see a lot. Individual states are looking at this, and I think I did list that in the slide of that's things that I believe Democrats will look at in the House. I don't think you're going to see it passed federally. So look to states for help on out-of-network providers, which can be a big, big problem.
Okay, great. How will the election affect upcoming mergers? Example, CVS, Aetna, etc.
Not clear. I think that mergers will continue. And even though Zach Cooper has shown us that when mergers continue, that sometimes prices go up, I think it's so complicated and it's so hard for small hospitals or small medical groups or even small insurance companies to survive that consolidation is going to continue. I don't see any change in that. And the few times I go to Manhattan to talk to folks that know a lot more about this than I do, billions and billions of dollars are going into smart venture capitalists who think that they'll be able to figure out who the Uber for healthcare will be. Will it be Amazon, Berkshire Hathaway, and JP Morgan Chase? Will it be the CVS merger? We just don't know. And again, those things get complicated. Last time I looked, the federal judge was still saying that he wanted to weigh in on the CVS merger and saying to CVS, and I believe it's Aetna, don't go so fast. I want to talk about this. So there's still that tension between consolidation and federal trade guidelines.
Mm-hmm. Why do you think that the GOP keeps attacking or limiting healthcare coverage when clearly it's a winning message for the Democrats? Seems illogical.
It may be illogical, but remember, the Democrats, healthcare is something they care about. Healthcare is something there's a lot of expertise. One of the problems the Republicans had in repealing and replacing the Affordable Care Act is that the staff people on the Hill and in Senate were not that sophisticated on the Republican side. There aren't that many staffers on the Republican side who are really into healthcare. And so part of it is, I think, if you're a Burkean conservative, that's Burke, the famous English conservative, you just want to get the federal government out of as much things as possible. And I think that although the American people tend to be now swaying toward a safety net is important, I think for people that really care about conservative values, they don't like the idea of the safety net and of requiring people to have health care insurance. I agree. I think that public opinion has shifted now. I mean, it certainly wasn't 10 years ago that 70% of Americans would say, yes, I think Medicare for all is a good idea. I think what's changed is that 20 million or more than 20 million people now have health care insurance who never had it before. And not having health care insurance is not a good thing. It causes bankruptcies, it causes death. And I think that ship has sailed.
So related to that, is there a GOP alternative to ACA? And if not, why not? It seems unfair to criticize ACA without offering an alternative.
I listed there, Avik Roy has an alternative, and Douglas Holt-Eakins has an alternative. But again, part of that was that when they voted on this in Congress, they really did not have an alternative that the entire Republican House agreed on. You may recall that Paul Ryan had some problems with trying to control his moderate group and also his more conservative group. And so part of the problem is the Republicans don't have a consensus on how they would replace the ACA. And that was one of the biggest reasons why they failed to repeal it.
Shifting topics slightly, reinsurance is not understood. Isn't it the same as high-risk pools that have been proven to not work?
There's been some experience with high-risk pools that don't work. The recent experience, it all depends on how you design it. The recent experiences with Alaska and Maine and some other places with reinsurance looks like that it can work better. And the only time we have the total results is from Maryland, and it looks like it did work in order to lower premiums in Maryland. So again, as usual, the devil's in the details. It's not that all reinsurance programs are good or all reinsurance programs are bad. It depends on how you implement it.
Mm-hmm. Okay. Seems like there's this tension between keeping costs down for the population an organization is accountable for and driving as much profit for the population you're still in fee-for-service contracts for. What to do?
Well, I think that if you look at healthcare experts on the right and the left, they all think that we should transition from fee-for-service, which encourages overuse, and go to value-based payments. That's in the MACRA and MIPS bill, where they're trying to get healthcare systems and doctors to embrace alternative payment methods. Alternative payment methods are things like value-based payments, where a system would get money up front to take care of a population of people. That's why population health is now the new buzzword, and why many of the keynotes I give around the country are on population health. What the heck is it? That value-based payments would discourage overuse. So if you're on a fee-for-service, which still most of America is, you want your hospital filled up doing as many procedures and surgeries as possible. If you're getting a single payment to take care of a population, you want your hospital empty and you want your ER empty, because every time you have an ER visit or a surgery or an x-ray, or dare I say a pathology bill from the hospital, that's money taken away from your ACO, from your accountable care organization, which is trying to better manage your population. So this idea that we're going to value-based payments, and some parts of the country are already there. I think Seattle, Minneapolis, and maybe Los Angeles, there's a lot of private value-based payments going on, but there clearly is a tension between fee-for-service, which most of us know and love because it's easy, and value-based payments, which most of the intellectuals think is the way to try to control the cost. Remember, if healthcare continues to grow so much, and in that National Health Expenditure Report from last week, they're still saying that they believe that by 2026, that the part of GDP that is controlled by healthcare will be almost 20%. If we have 20% of our economy going to healthcare, that means we don't have money for a wall, for ships, for infrastructure, for bridges that are falling down, for education, for the ecology, for national parks, whatever you like. If money is being eaten up in the GDP by healthcare, that's a problem. That slide I showed early on, which says, well, other industrialized countries are able to do their healthcare for half as much, for $5,000 per capita as opposed to almost $11,000 per capita. That's why healthcare prices and healthcare costs are unsustainable.
Okay. And then final question, just because of the time, can you comment on how healthcare systems, especially community healthcare systems, meeting market share and commercial payers, should treat Medicaid population as a business opportunity by engaging that population with a social determinants of health strategy to move care from the ED to PCP, lower cost setting, and turning those population members into financial solvents with jobs and eventually on employer benefits, commercial payer plans where reimbursement rates are higher?
It's a great question, and it really talks about all the things we teach at the Jefferson College of Population Health. And I guess I would encourage the questioner to take a look at the Thomas Jefferson University College of Population Health. Maybe think about coming to our academy or coming to our colloquium, which happens every March. That's a very difficult question, but it's one that I think is important. I think that by focusing on the social determinants of health, things like food deserts, things like why is it that people in one zip code live 20 years longer than people in a zip code 3 miles away, that you could actually become a system that is financially solvent, but also addressing the needs of your community. The problem is that most of our money now goes into a sickness system of hospitals and things, and we don't put the money into the social determinants of health that we need to. I would love to talk more about this. I give a whole hour-and-a-half keynote on just this exact question, but I don't think I can do it in the space of time here or in 140 characters on Twitter. But I would
sounds great.
I would encourage everybody to follow me on Twitter, because you will get more links to more white papers than you can possibly read, and then you can give this webinar and I can just listen.
Excellent. On that note, Kent, thank you so much. It was a fantastic webinar, lots of knowledge, lots of new information, and we greatly appreciate it. Thank you.
Thank you.